In CML, we had all these TKIs approved, and I think all were overdose in approval because we follow what we call the MTD classical schema to find an MTD and proceed with the phase 2 studies. So Ponatinib, very potent TKI, very effective against BCR-ABL wild type and mutated, and had other targets, was explored at 45 mg per day. Very good data. Essentially 60% are responding, 50% are regaining their CCYR, and the survival at the long run is around 80% in patients who failed multiple TKIs. The price to pay was that this patient did develop vascular events, about 13-14% of the cases, be it stroke, any vascular problems. So therefore, we went back and we look at the data, we look at the disease and what's going on, and what we found is that it's dose dependent. Every increase by 15 milligram, you increase the risk of a vascular event by a third. Therefore, we said, well, can we decrease the dose and see how it goes? So now, in a PACE trial, where it's prospective trial done, the dose adjustment of Ponatinib for other reasons of toxicities, but not for vascular, did not compromise on efficacy. It means patients who reduced their dose did maintain their efficacy. Therefore, we designed this OPTIC trial. Well, we said patient was at 45 milligram per day and have 3 arms. 145 reduced to 15 once a good response is obtained, means CCYR or PCR of 1% or below. 130 milligram and 15, 115 all along. And we showed that this, like, if you dose adjust based on response, you optimize the safety. We reduce the risk of vascular event without compromising on efficacy. What we did at SOHO in this paper, we did combine, we did compare in a PACE 45 reduced based on toxicities, OPTIC 45 reduced based on safety. So we look at the only 45 milligram starting dose to be equivalent, and we showed that with 45 reduction to 15, as in a PACE, we did not compromise efficacy. In fact, efficacy is better, but we reduced the safety concerns in a major way. In a way, we had less vascular events on Ponatinib, more drug exposure, and further outcome. And this consolidates the fact that we should dose adjust if we want to improve on safety without compromising efficacy.